Melanoma Matters is an educational resource, and the opinions we express are our own and do not reflect medical advice. If you have questions specific to your own situation, please contact your own clinician. This podcast may be available in both audio and visual, so please check your platform.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
We're going to talk the Merlin 001 study today and the Castle gene expression profiling tests. Basically, these tests are in the kind of journey for a patient when they are deciding about a sentinel lymph node. And we're going to kind of talk prediction of positivity of a sentinel lymph node, and then also prognostic value in those that have a positive test, in those that have a negative test. That's going to take, in one of the studies, it's certainly going to take a little bit more time to flesh out. But any quick fires you want to do?
I don't know. We were going to talk about bombastic, weren't we? But then I thought maybe I should ask you. You know who Merlin is?
A wizard?
Yeah. Any more?
Gray, purple, cape. What would you like?
Surely most wizards wear
Camelot?
grey or purple. Yeah, that's
Camelot?
good.
Okay.
Yeah. Any more?
King Arthur?
Yeah. And do you know where King Arthur's castle is? The whole thing's probably mainly fictitious, right? You know that. But do you know where King Arthur's castle's meant to be?
Where his castle's meant to be? No.
His castle as well. That's good, isn't it?
Awesome.
That's the link. Merlin Castle.
Oh, yeah. Cool.
So do you know what the answer is?
Cambridge?
No. Somewhere in the southwest of England.
Cornwall?
Good. Yeah. A place called Tintagel. Tintagel.
Is that a place where your office mate just went on holiday?
No, don't think so. I can just check though. Did you go to Tintagel on holiday, Andrew? Nearby, but not Tintagel. But you can see it, Tintagel Castle, actually, from the house I grew up in Port Isaac, because it's sort of across the bay. And it's actually very pretty. It's on a sort of rocky promontory that you can only get to on a bridge. So interesting piece of trivia. Yeah.
Very nice. That's good.
Right.
That's a cool little unexpected linkage.
It was, wasn't it? Yeah.
Like
right.
that.
Go on then. You know all about this.
Yeah. Well, I'm happy. I kind of really went into the Merlin one because I've heard it now at a couple of recent talks and read it. It's available in the US, so it's commercially available to order. It's reimbursable. I think there's some numbers in here about that. But maybe you want to tell us about the manuscript and the title and authors and everything.
Yeah, let's do that. So Merlin 001, JAMA Surgery, published online October 25. Corresponding author Vern Sondak, and then lead author Tina. Now I need to get this right. Heiken, is that right?
Very good, very good. And you call Vern, not Vernon, like so many Europeans do.
Yeah, is that okay as well?
Yeah.
But Heiken is Hiek, right? So the pronunciation rules would be Heiken. But I mean, I don't want to go into a sort of rabbit hole on that either.
I will introduce you at ASCO. She'll be tickled, I'm sure.
Really?
Also, maybe as just a little quiz, any idea what Vern Sondak's favorite beverages are? If he was having an alcoholic beverage. Did he have one that night we went to dinner?
Probably, but I've already forgotten.
Did you?
Yeah, but you haven't, obviously.
He's a margarita guy.
Is he?
He's a margarita guy and a Diet Coke guy.
Okay.
Yeah.
Yeah, I'll try and remember that now. So then the other thing maybe to say about the authors, this is a load of experienced melanoma surgeons. They actually say that in the abstract. and the study recruited September 21 to June 24 at 9 academic medical centres.
Got it.
So that I think that's all important stuff, actually. Right, enough.
Yeah,
Do
I mean,
you want more?
I always want more. The authors are essentially primarily surgeons. I'm not sure if there are any medical oncologists. Presumably, there's somebody from the company on here. But yeah, your point is actually absolutely right. That's why it's in such a nice journal. You know, JAMA Surgery is a really preeminent journal of the JAMA family. And the primary objective of this study was around the predictive capability of this Merlin test. This Merlin test is what's called a clinicopathologic gene expression profile. So it's, genes, 8 genes that they look at the expression levels, but then they add it to 2 clinicopathologic features. So the primary objective is, what is the predictive capability of this test to be able to identify patients who are low enough risk that they could skip a sentinel lymph node biopsy procedure. And maybe just going back a little bit further, and for those who are interested, our episode with Mark Ferries, which we need to put in the fact check, I went and listened to it recently. It's just such a really nice history of the sentinel lymph node. He talks about the Sunbelt trial, then MSLT1, how it led to MSLT2. And it's a nice, I don't know if we teach our medical oncology trainees this history of surgery, but that's a nice one, doing completion dissections on everybody, or doing sort of full, dissections on everybody, going to sentinel lymph nodes, doing them early versus later. Early seems to be better, but then completing a dissection in those with early found sentinel lymph nodes, no benefit. So that's a nice kind of tie-in. I'll try to link it in the notes or in the YouTube. So I kind of lost my train of thought there, but yeah. So just for historical context, and Mark actually said this at a meeting recently. He called it terminal digit bias. So surgeons will often counsel people where the nomograms say that their risk of a sentinel lymph node is greater than 10%. They'll often counsel them, we should probably go looking. And for those who are less than 5%, it may not be worth it. And for those between 5 and 10%, let's talk through it and make a kind of, informed concurrent decision. And what Mark said is, where does that 5%, 10% cutoff even come from? And he calls it terminal digit bias. Nobody really knew, although another surgeon, Charlotte Arian, said, maybe it's, you don't want to do a procedure for something with a less than 5% risk where the kind of morbidity of the procedure might exceed 5%. So wound infection, lymphedema, pain, etc. So anyway, that's sort of the guidelines. If you use a nomogram and it says the risk of sentinel lymph node is low, a lot of people will probably say maybe we don't have to. So the question is, do any of these gene expression profiles identify that population for you? That was the kind of primary objective of this study. Can you get a negative result, or a low, I think is how they report it. I need to remind myself. Yeah, a low risk report. And will that help you identify the less than 5% of patients? If it puts you in the 5 to 10%, you're still in the situation where you need to discuss it. And so there's a second objective of this study, and it's also to just determine the prognostic value. So after people have a negative sentinel lymph node, how good was your Merlin test at sort of determining your prognosis? That's going to take some time, so that's not reported in this manuscript.
But I think your first point's critical, right? Big picture, because we're going to get into some detail here, aren't we? And when you go to meetings and there's discussions, you get into the detail quite fast, and there's all these different subgroups and all this sort of stuff. But just thinking about it in the top line way, the question is, have you got a non-invasive test that you can use with confidence to omit? That's the crux of it, isn't it?
That is the crux of it. And why would we walk away or move away from these nomograms? Well, there's two main ones in use. There's the Memorial Sloan Kettering nomogram, and there's the Melanoma Institute of Australia nomogram. And there's a couple, those are basically based on purely, almost purely clinical features with a little bit of pathologic features. But the Memorial one, for example, still uses Clark level. And Clark level is, to my knowledge, no longer part of the College of American Pathology synoptic report. So this is the Clark level 1, 2, 3, 4, 5 Roman numeral, essentially the kind of anatomic level of skin to some degree, but we don't see that anymore. So, the Memorial one still requires that in order to give you a full picture. The Melanoma Institute of Australia asks you for the histological subtype. So is it a nodular? Is it a superficial spreading? And actually on a biopsy sample, because it might be a shave, you may not have the full histologic subtype. So it may say a spindled neoplasm, an epithelioid neoplasm, scant cytoplasm. It may say stuff, but it may fall short of actually telling you if it's a nodular or a superficial spreading or, so, we're looking for kind of more modern tools, I suppose, is the way to say it. And do you see in their table 1, do you want to maybe tell us what these 8 genes are?
Yeah, I mean, I'm not gonna read out the names of all the different genes. One of
Okay.
them's I can do. One of them is interleukin 8. I was just going to do highlights. Integrin B3 or beta 3 is another one. TGF beta receptor type 1. There's 3. And anyway, so that's some of the genes, and then
Melon A, I think.
that's the top one.
Right.
And then you look at the right-hand side, which is putative function, so the genes on the left-hand side, and then almost all of them listed out as being involved in angiogenesis or EMT, epithelial to mesenchymal transition. So I suppose you could say, looking at the list, that all sounds pretty biologically plausible, is the first thing. And then the second thing, and I look,
on there.
is it?
Yeah.
Oh yeah, so it is.
TDF15.
That's very interesting.
Isn't
Yeah, but
it?
I mean, all I would say is that, and I went back and I tried to look at this about how these were established in the first place, but effectively what happened, and the citations are in this paper, is that a load of melanomas were collected. Yeah, and so they've sort of been derived, and so it's not really surprising in a sense that you've got this list. It's absolutely plausible, but does it tell you anything biologically? I'm not sure is what I was going to say, but carry on.
Yeah, I mean, you could say the same thing about any sort of gene expression profile that narrows itself down. I didn't read how they did it. You tell me if this is correct or not. But generally, you do sequencing. Then you look for somewhere on the heat map or somewhere on the plot where it discriminates between, in a binary fashion, typically. So it discriminates either high, low, positive, negative, whatever. And you're going to have, depending on what you sequenced, you're going to have 100 genes on one side and 100 genes on another, or 100 genes that can discriminate that kind of high, low mark. And then you just do kind of unsupervised clustering and deductions where you reduce the genes by 10%, 25%, 50%, and do they still discriminate into those two groups with high sort of fidelity? What that might be, I don't know if that would be 99% or 95%, but that's essentially how it is. And so, yeah, I mean, if you're going to start with, there's a host of genes that kind of separate low and high risk, that some of them are involved in either melanogenesis, angiogenesis, or EMT, as you said, maybe that's not surprising. But what about the two clinical pathologic criteria? Do you know what are the two clinical features?
You asked me that before, didn't you? One of them's
Yeah.
thickness, isn't it? Isn't that right? And
Yeah.
then isn't the other one age? I can't remember.
Yeah,
No.
yeah.
What,
And
2
what
out of
does,
2? Did I
yeah,
get
you
2 out
got
of 2?
it.
100%.
Good
Brilliant.
memory. This is our take 2 recording, technically. So, and did we ever bottom out what happens with thickness over age, like with age, with increasing age? Do
Oh, what?
tumors, yeah,
Get
what happens to
thinner or
tumors?
thicker?
Mm-hmm.
Well, I would guess thicker, but you tell me.
I don't actually know the answer, but I do notice surgeons will often say that there's an inverse probability of sentinel lymph node positivity with
With
age, right?
age,
So the
yeah.
younger patients, positive, older, less. Okay, so 8 genes, 2 clinical pathologic criteria, and that's the CP-GEP that makes up the Merlin 001 test. And so let's talk about some key points here. They enrolled patients with T1 to T3 tumors, clinically node negative, so nothing on ultrasound or on physical exam to suggest they had clinical positive lymph nodes. They enrolled 1,761 patients in this observational study. They reported according to, I think, Strobe reporting guidelines, which is different than the consort we're used to for randomized trials, or probe that sometimes we use for randomized trials. And of these 1,761, they were T1 to T3. They were blinded to their GEP result. So that GEP result did not influence whether or not they went for a sentinel lymph node, or didn't influence, I guess, what came next. They all went for a sentinel lymph node. So based on an archival cohort of 754 patients, they felt that their low risk test had a negative predictive value of 96%. So do you remember how do you teach negative predictive value?
Not as well as you. You've got it at your fingertips. No, it's true.
Negative
I always have to go back to the start and think about what it means.
Negative predictive value is the probability that a negative test
Is correct.
is correct or picks up a negative population. Yeah. So they had a 96% negative predictive value, meaning only 4% of patients with a negative or a low risk Merlin test in their archival cohort had a positive sentinel lymph node. So a low risk result there really most of the time means low risk. So it minimizes your false negative rate. Is that right? Yeah, minimizes your false negative. Yeah. Okay, because T1A patients rarely are going to have positive sentinel lymph nodes. They took T1A plus one other high risk feature that was defined as age less than 40, a mitotic rate of more than 2 per millimeter squared, or the presence of lymphovascular invasion. And then what this study describes is the observed positive sentinel lymph node rate. And then it describes what is that positive rate in those with a low risk Merlin test and a high risk. So they also describe a positive predictive value. So what's the chance of a high risk test resulting in a positive sentinel lymph node? So basically a true positive, if you will. So then it was 17.6% positive here. So in these 1,761 patients, kind of easy to remember, 17.6% had a positive sentinel lymph node. 37% of patients in the study had a low risk result. 63% had a high risk result. Of that low risk group, 7.1% had a positive sentinel lymph node. So that leads to a negative predictive value of 92.9%. You're smiling.
No, I was just thinking about. I'm sure I've told you this before. Martin Gore's rules for efficacy when you go from phase 2 to phase 3. Have I told you that before or not?
Is it like a nice edict we need to remember?
Well, it's probably overly harsh, but he basically said you need to halve the response rate between phase 2 and phase 3. Old school.
So what about all these phase ones that are going straight to phase 3?
Yeah, I think phase ones are so heterogeneous these days. I don't think you can make any, because some of them are verging into phase 2s already, actually, aren't they?
With a response rate of 80% and then going
yeah,
down to
devil's in the detail, I think, with phase 1
Yeah.
studies, isn't it? This is an old school rule, probably mainly based on cytotoxics as well. But anyway, carry on.
63% of patients had a high-risk Merlin test. The positive sentinel lymph node rate in that group of patients was 23.8%. So the positive predictive value there is this 23.8. You should have more in the high-risk group than in the low-risk group.
Well, I mean, exactly. Were that not the case, then alarm bells would be ringing. I mean, that's kind of what it says on the tin, isn't it?
Yeah. What else can I tell you? Okay, there's a little bit of caveat here in the stage 1B patient population. So this should be like the T1Bs, and maybe T2A classifies as stage 1B. That made up 67.4% of the study. Nearly half of those, 49.3%, came out with a low risk test result. So stage 1B, nearly half came out with a low risk test result, but 12.5% ended up with a positive sentinel lymph node. So is this test that useful in that stage 1B population? It may not be. In the group greater than 65 years old, so in your patient population older than 65, that's 47.2% of the study. I wrote here 42% of them had a low risk result, and their sentinel lymph node positivity rate was 6.6%. So both of these groups, stage 1B and age greater than 65, are coming out with kind of, even with a low risk test result, are coming out with a high positive sentinel lymph node rate.
And are we allowed to do all these subgroup comparisons, do you think, as well, or not?
Well, they're not really comparisons. Remember, the study doesn't have like power so much to it. It's more trying to say, does a low risk test identify a group of patients with a less than 5% positive sentinel lymph node rate in whom you can forego the procedure?
And the short answer, that's no, isn't it? Because it's 7%,
No.
right? Yeah.
Because overall, in the low risk group, which was 37% of the population, the sentinel lymph node positivity rate was 7.1%. So in that please discuss range. In the stage 1B, it was 12.5%. So greater than that sort of 10% terminal digit cutoff of maybe we should do it. And in the age greater than 65, it was 14.5%. So perhaps in those latter two categories, this Merlin 001 test may not be that helpful. And they say that in the discussion. But they also carefully say, look, 5 to 10% discuss is also a bit arbitrary. And maybe in your patient population who is more frail or has more comorbidities, maybe less than 10% is the cutoff for where you may not proceed with surgery, sentinel lymph node biopsy, and you would just monitor the lymph node basin. So they sort of say that in discussion, maybe there's a group, but that would be a bit of a paradigm shift. And it would be, obviously, this is a surgical discussion to be had. I doubt very many medical oncologists get ensnared in this discussion. But as they might come to us or see us in a multidisciplinary fashion, it's good for us to maybe have an opinion about it. Then what about those T1A high risk? So the T1A age greater than or age less than 40, mitotic rate 2 per millimeter, 2 per millimeter squared, or lymphovascular invasion. There was a very small percentage of those, 1.5% of the study population, 26 patients in total. Only one had a positive sentinel lymph node, and that was in a patient with a high risk result. 5 patients had a high risk result. The one with the positive lymph node was in there. So that's a 20% positive predictive value, and then essentially 100% negative predictive value for the 21 out of 26, but too small, really, a group to say anything substantial about. So I guess that's it. It's a nicely done study. It's an observational study. It's real world how our surgeons are really approaching this. And so they rightly say the study was negative for its primary objective. No, a low risk test does not help you identify a group of patients who can just simply forego a sentinel lymph node biopsy if the conventional cutoff is 5%.
I completely agree. And so it's complicated, isn't it? And what I was really going to ask you is that, how do you think this is going to play? Because even doing the test in the first place has got some complexity attached to it. In other words,
Yeah.
what are the situations in which you would do it? And it's quite specific, actually, isn't it? And so,
Yeah.
do you see that this is a test that in those situations it might be used, or do you think there's a possibility that people are just going to do it all the time anyway, and the patients are going to kind of lobby the clinicians to have the test done, and then you're going to end up in a situation where you're doing a test that it might not actually influence the way that you think about this? So go on.
Yeah, I mean, that is a fair point, and I would love to hear from our surgical colleagues. It may be beneficial, but ultimately it is going to be the surgeons who order this. But there's a lot, right? This is always going to be on the primary specimen. So where is that primary specimen? It may not be with a surgeon. It may be at a dermatologist's office, a GP, or a PCP's office. And then what's the turnaround time? And I'm sure our surgical colleagues will tell us all of this. I wonder if it's going to change them to want to use the test to help guide a conversation.
Yeah. Okay.
But
I guess.
it then also requires like another pre-op visit, because you won't have this at the first pre-op visit.
And complexity, actually, because you could have a result that actually requires quite a lot of discussion and nuance. And I just feels in some situations that it might slow things down, actually, as you've said already. But yeah, I think that's fair enough. Anyway, well, I mean, maybe the big picture is that this is a really nice paper, and it's a great effort. And
It's well written, I have to say.
Yeah, and this in general is the shape of things to come. There's no doubt about that at all.
Yeah.
I think it's a question of the technology being right, and and they've done a nice prospective study. So I think it's pretty good. Congrats. Are we
Yeah,
done? Are you?
congrats to them.
Yeah.
So now we're going to move on to the Castle test. And the article that we're reviewing here is the Integrated 31 Gene Expression Profile Test identifies low risk patients with cutaneous melanoma who can forego the sentinel lymph node biopsy procedure. Results from a prospective multi-center trial. First author is Timothy Beard. Senior author is Sean Young. And this is published in Future Oncology, February 2026. So do you want to take us maybe through the abstract and the kind of design?
Yeah. Accepted February 26th. I reckon publication might have been March, but I'm splitting hairs slightly. Okay. So T1 to T4 tumours being considered for sentinel node had this 31 gene expression profile test. The study's called DECIDE in capitals. 912, N equals 912, and RFS was estimated. So this is the abstract. The positivity rate of the patients who had a sentinel node was 2.6% in those with a less than 5% gene expression score effectively, versus 21.4% in those with a greater than 10% predicted risk. And then, so that's all overall in T1 to T4. And then they split out T1 to T2A, which is 360 patients. And then the kind of analogous rates are 1.8% positive sentinel nodes in those predicted less than 5% versus 16.7 in those with greater than 10% predicted risk. And they also say the 3-year RFS rate was 97.8% in those with a less than 5% predicted risk. And so their conclusion is that this test with sentinel node identifies low risk patients who might consider foregoing the procedure. So Go on.
And it's a 31 GEP with integrated clinical pathologic features of Breslow thickness, mitotic rate, age, and ulceration. So, the two clinical pathologic features in the Merlin test, they appear here with two additional ones, mitotic rate and ulceration. Maybe a little bit about study design here. So when did they test? What did they do with the test results?
Yeah, I mean, this is the crux of it, isn't it? And I think with all due respect, it's linked to the journal as well, isn't it? Because we've just been talking about Merlin JAMA surgery. This is in Future Oncology, which is obviously not a journal with the kind of impact and readership that JAMA surgery has. So following the test, the physician provided the result to the patient, and the decision to either have or not have sentinel node was made, and it says with shared decision making based on all the factors. So that's the kind of existing factors and the results of this test and patient preference. So go on.
So like most IRBs, let's say at my current academic center and my previous, they would not have allowed for this. It's a test that's not been validated for prospective use. And then using that to make a clinical decision, shared or not, and other factors being considered, that test is going to weigh on your mind. You get a low risk test, or you're still going to put your hand up for a surgery with general anesthesia. But the problem is the test hasn't yet proven itself. The characteristics of the test haven't proven itself. So most IRBs that I'm aware of would not have allowed this to go through, because you are using a research test that should remain as research to make clinical decisions. Compare that to how the Merlin study was done. The Merlin test was performed on all patients who underwent a sentinel lymph node, but they did not get the results of it. The provider did not get it. The patient did not get it. In fact, it was only Vern Sondak who had access to the database and the results of these patients, and an independent, data monitoring committee. The surgeon and the patient were not influenced by the result of their Merlin test to go left or right. It was performed. They were not going to know the results of it. And so the fact that this test was shared, and then patients and providers made decisions with that information, it's a problem. It's kind of a methodologic problem.
I completely agree, and I'm not even sure we can take it any further, actually, as a consequence of that. Because what does it mean? And which is a shame. Go on.
Yeah, just to bottom it out. First of all, would this have passed the Marsden's IRB?
No, wouldn't have passed anywhere in the world, I don't think.
Well, it did. I mean, it did. I guess just to really bottom it out even further, if the test is wrong, so this research test, well-intentioned, if it's wrong and a low-risk test does not have a strong negative predictive value, you have now made a clinical choice on a patient to forgo a sentinel lymph node biopsy, which we know has prognostic benefit.
And you might have had, let's say in another world, you ended up having the sentinel node and it was positive, and you had adjuvant treatment, and it reduced the risk of your melanoma coming back. Then that's potential harm. Which is why the IRB's ethics committees on our side of the pond, as it were, would say no. So I honestly, I mean, we've read out the findings already. I'm not really sure that it's easy to state this any further. Actually, it's a cherry pick group by definition on an unproven test. Period, as you might say. I think if we're honest as well, I mean, if you read the discussion, and you get to the final paragraph, strength of this study, blah, 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 and then limitations of this study, blah, 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 which is the final sort of 7 lines or so. I mean, if I'd been reviewing this paper, I would have had something to say about that. And, with all due respect to the journal, I don't think you can omit the discussion that we've just had from the discussion of the paper.
Yeah.
Actually. Listen, unless we're both missing something.
So Merlin test, a low risk test doesn't help you forego sentinel lymph node biopsy. but they're a little bit thoughtful about their discussion. The Castle test, i31-SLNB, not so sure.
Yeah, good place to stop. It's quite long as well. Maybe we have to divide that in half. I don't really know.
All right, thanks.